is bad and decreases survival. It's really bad. Having TR is bad. And having MR and TR is like me having two flat tires at the same time. I go to the garage, and the mechanic comes out, he's only got one tire. Actually, the mechanic looks just like this for some reason. That's Azim. And he says, I only got one tire, so I can only fix one, but I'll fix your MR. That's the only thing I can see right now, and you'll be fine. No, I won't be fine in a car with still having one flat tire. TR is bad. And amazingly, even percutaneously, if you leave them with TR, it's bad. That's because it doesn't matter how you deliver the annuloplasty ring. If you leave TR, the patients are going to die. TR is bad. Fix TR. So, TR, no debate. Moderate to severe TR is bad. We all know that. Does TR go away if you fix the MR? No, this is 5,000 cases from the Cleveland Clinic, 16% of which had severe TR, and at discharge 3 days later, they all had severe TR. It doesn't go away. And despite a good mitral result, that's why it's irritating that years later, months and years later, TR can come back. There's no guarantee of getting rid of that TR and it getting better. That's because it's become like a stretched rubber band, and in many cases it's actually broken. And that's why the size of the annulus is very predictive of whether the patient is going to have a recurrence of this TR. And in fact, that is actually very mathematically straightforward. If everyone does this in the room, that is the size of your native tricuspid valve. It's 28 millimeters, very tightly controlled. And in fact, if you get up to 35 millimeters, almost half the patients will have TR. And if you get to 40, everyone has TR. So there's no debate. Moderate to severe TR is bad. And the dilated annulus is bad. Everyone knows that, Azim. So, does it matter if we do an annuloplasty? This paper by Gilles Dreyfus, 300 patients or so had a mitral valve repair, and half of them got an annuloplasty. Now, these patients didn't have severe, they didn't really even have moderate, they had less than moderate, or just a dilated annulus. And if you look at how they did 2 years later by Azim's theory, 50% of them progressed to severe TR. By my theory, we put an annuloplasty on them, they did fine. So what about undersized annuloplasty? Well, it's really not undersizing it, it's really re-normal sizing it. Put a 28 ring on everybody, you'll do fine. This is Jim Gammey's paper. You can see very little recurrence with a re-normal sized ring. Are there other series that show this? This is David Adams, 645 patients. The same thing, far less recurrence of TR. Better RV function because the RV does not like to do all that volume work when you take it away. They do better. And this is our series, 262 patients exactly consecutively by the guidelines with a 26, 28, or 30 ring. Only 1% of those patients went on to progress their TR. So there is no debate. Moderate to severe TR is bad, a dilated annulus is bad, and the tricuspid annuloplasty is good. So what about Azim? He's going to tell you about some not annuloplasty things. What? Yeah. So it's this percutaneous redux force. These things at the bottom of the Vega annuloplasty or K annuloplasty, they failed when I was able to look at them with my own eyes. It doesn't work. The only thing that works, Azim, is an annuloplasty. And here's an example, the trial line, which is really just a percutaneous capitulation of a K annuloplasty, except you cannot see what you're doing, doesn't work. Here is the compassionate view to the trial line, the K annuloplasty. Goal accomplished. See what they left? A 10 centimeter square area of a tricuspid valve. That's that big. And in fact, the ERO was 1.5 square centimeters. That is 400% larger than severe. Seriously, Azim? That's not good for patients. However, what Azim has done is tried to move the goalpost down the field. What TR goal is good enough with his not annuloplasty theory? Well, grades 0, 1 is what I want, and 2, 3, 4, of course, are bad, and now they've invented these new categories, 5+, which is massive, 6+, which is torrential, and I think 7+ is tsunamic. And so if they could move it from tsunamic to torrential and say the patient is all better, I don't think so. So, in summary, TR is bad. And really, the biology of TR will not change with the method of therapy. Whether I get it there surgically or percutaneously, I'm okay, but it has to be an annuloplasty. It's annuloplasty for all, and no TR is the best goal. I have no TR right now, and I want none, and I will do best. Certainly less than 2+, because Jan has showed us TR is bad, moderate to severe is bad. And not something else azime, and not something less azime, and not nothing azime. So, there's no debate. Moderate to severe TR is bad, a dilated annulus is bad, and an annuloplasty is good. But I will have to say, azime is good. Is this misguided? So, TR equals annuloplasty. TR is bad. And what we really need is sustained, meaningful TR reduction. And now the debate is over. Azime is packed up and left because he's lost. Thank you.